Hello, I'm Solomay Tibabu. I'm the host of the Going Digital Behavioral Health Tech Conference. I am so thrilled to have Dr. Rosenzweig and Dr. Ross here with us from Optum Behavioral. Welcome. Please introduce yourselves.
So hi, everyone. I'm Martin Rosenzweig. I am the Chief Medical Officer for Optum Behavioral Health.
Hello, my name is Dylan Ross. I am a Senior Director of Clinical Strategy with Optum Behavioral Health, organizational psychologist and licensed mental health professional by background.
Wonderful. Thanks so much. Dylan, maybe I'll start with you to help us understand what is measurement-based care and why is it important?
You bet. Thank you, Salome. Well, as a part of my role here at Optum Behavioral Health, I have the not so small challenge of bringing measurement-based care to our broad and wide network of wonderful behavioral health providers. So what is measurement-based care? Measurement-based care is defined as the systematic collection of patient-reported measures used to monitor behavioral health treatment progress and outcomes. And with this, we can then use this to inform both clinical as well as organizational decision-making. And measurement-based care is important for a number of reasons. One, we know that as a field, behavioral health outcomes have lagged far behind those found both in the medical setting as well as in more controlled trial-based, evidence-based treatment trials. And so given the fact that we're aware of some of these gaps when comparing to both medical and more study-based settings, that some of the reasons why that is that we don't see the use of standardized measurement adopted broadly. And why this is important, if we think about this at both the patient level as well as the provider or practice level, when we omit the use of standardized measurement, we're somewhat flying blind. And to cite an often kind of referenced example, imagine going into your primary care provider and you're receiving treatment for hypertension, high blood pressure, and you went in and your primary care provider failed to use a blood pressure cuff and just ultimately asked you, so Dylan, how is your blood pressure since the last time I saw you? In essence, that's what the most common practice out there today is, that very few behavioral health providers are using measurement-based care or standard measurement. So why it's important at the patient level, studies suggest that with clinical judgment alone, we know that behavioral health providers most only effectively detect symptom deterioration, i.e. worsening symptoms in patients upwards of say 19% of the time. So consider that. That means over 80% of the time, behavioral health providers are likely missing really important clinical signals around their patient, the person they're providing care to, is getting worse. And when you look at this from a detection kind of standpoint, when clinical judgment is used, i.e. measurement-based care is not being practiced, that for patients who are not getting worse, that this is ultimately, so just basically stagnated care, not seeing improvement, but also not seeing decline, that providers are even more challenged to pick up on that. So what that ends up doing is it draws out the treatment episode and makes it an ultimate challenge for both providers as well as patients to have access to measurement-based care, which is a really important evidence-based practice.
Wow, that's super eye-opening. Thanks, Dylan. So Martin, can you tell us a bit about what is Optum's plan to expand the use of measurement-based care?
Sure. So, one of the roles, obviously, as of Optum or United as sort of a large payer, is to make sure that the care that our members are getting is effective and that we're actually able to demonstrate that. So there is a lot of literature or research that's really shown that measurement-based care has immense value to the system when you look at it sort of overall, from a quality point of view, from an outcome point of view, in terms of really being able to align resources that are under pressure right now. We all know, under COVID, there's been increased demand for behavioral services. So we really want to, as a large payer looking systematically, really understand what is the best care? You know, how do we align with those sort of quadruple aim? So we're very committed to this. Dylan runs sort of our initiative around measurement-based care, and we're pouring, significant resources into this in terms of trying to understand what we can do to better implement this in the delivery system. Now, we know this is not simple. It's not, just handing out a PHQ-9, when you see a patient once a year. That's not measurement-based care. We understand that we need to learn a lot more about what are the barriers to implementation. And clearly behavioral services get practiced in a lot of different settings. So we actually are committed to having a whole bunch of pilots where we are trying to find actionable answers to that implementation conundrum. The other piece is, we have discovered, I think, in our journey around the country with some providers, that some of them have already developed systems. So part of why this is important is we're trying to figure out the interchangeability around data sharing. So if they already have a system that works, that they've implemented, how do we sort of port that data or use it in a way that really would help us understand and improve the outcomes for our members, for patients? So this is a deep commitment on our part to really improve and drive greater adoption of measurement-based care.
And I would say it's a huge departure from what is standard practice out there. We have one of the largest behavioral health networks in the nation, and which is reflective of what the industry is doing out there in terms of the community. And studies suggest that only upwards of 10% of psychologists are using measurement-based care routinely, and 19% of psychiatrists, so physician providers. Unknown in terms of master level providers, and knowing how many master's level licensed clinicians are out there practicing, it's likely much less than the 10%. So we've got, the only direction we can go is up from here. And hence, to Martin, your point, this really is an implementation challenge. We need to identify what are those factors that are the contributors that promote adoption, use, and sustainability of measurement-based care. And as we begin to break this apart, it's, as Martin mentioned, it's way more than just, say, collecting that routine PHQ-9. Measurement-based care is an evidence-based practice, which requires practice change at the provider level. And so this is not just drop a new technology in and hope that all of a sudden MBC is the way that business is done. This requires a huge adaptive change at the provider level, at the practice level. And one of our hopes too is that we can influence the landscape around us for the consumer themselves, for our members and for our patients, where this is expected. Where when, that example I gave in terms of, the lack of a vital sign being collected for your hypertension, i.e. blood pressure, that the new normal here in the future would be that patients expect it. And so this is something that we're fully committed to, and driving hard to really wring out those insights, both from a technological standpoint, interoperability standpoint, as well as a practice implementation and change standpoint.
That's really helpful. I mean, as you're talking, I'm just wondering, why isn't measurement-based care more broadly practiced? And it sounds like there are quite a few more nuances than just slotting in a PHQ-9 every now and then.
There's some real challenges out there to the collecting of systematic collection of these types of patient-reported data. So one is that we have a system that historically has been paper-based, and not all care delivery organizations have fully embraced that large leap forward to technology. Oftentimes, a patient who walks into the waiting room, this is kind of usual practice, would be given a clipboard, a paper, and pencil. If they're collecting that information, oftentimes that ekes into their clinical hour. That then often requires duplicative data entry on the provider's part, where perhaps there's not front office or back office staff to support. Oftentimes there hasn't been the appropriate incentives or reimbursements to put behind these, as well as there's a pipeline issue here in terms of training. and the prepared workforce that's required to really understand how to use MBC as a practice beyond just a transactional data capture. We need to make sure that from the very first point, when somebody seeks, steps into that training pipeline, that this becomes just a routine part of what's expected. And then the last call out that I would note is that for whatever reason in behavioral health, there hasn't been a strong embrace around the value of transparency. And ultimately, there's still outstanding questions around what's important to measure, how do we go about measuring it, and which tools matter most. And so I feel like we're actually turning the corner there as we start to see whether it's factions of CMS or NCQA, other quality organizations promoting the use and prioritizing outcomes-based metrics, that we're going to start to see this just becoming standard, which is a good thing. But there are plenty of headwinds out there, and so we're feeling them. Martin, anything to add with that?
Yeah, and I think one of the things that I get why it's not broadly practiced is people, many sort of providers or practitioners weren't trained in this way of kind of seeing care. So, typically the skills you pick up in training and maybe a decade after is what you carry forward in your career. We're asking, providers to think about things a little differently, even though the measures have been around forever. So that can be a challenge. If you're going to go into a provider and say you need would you consider changing some of your workflow? You have to have a compelling value case for that. There must be a reason to do that. As well. And the other sort of piece I think is hard is, we're looking at sort of diagnostically based treatment. Someone comes in with major depression or generalized anxiety. Some people kind of go into therapy for sort of less definite reasons, relational issues. It doesn't mean to say you shouldn't measure that either, because, just coming in every week and talking to someone, how do you know that it's actually helping? And that's part of the validation of, there's no doubt, I think the research is clear that psychotherapy works, but, it's sort of a useful to have a discussion with a patient about, no matter the reason that they're in therapy, is this helping? That's the fundamental sort of question that I think MBC, measurement-based care sort of strategies, helps address.
That's great. Yeah, I mean, you just basically said why patients should care. Is this even working? Can you talk more about that and other stakeholders like providers, payers, and policymakers? Why should they care about measurement-based care?
So there are several reasons, but I think some of the most important one, I think measurement-based care also allows us to really move into the realm of more sort of personalized medicine, if you will. We can understand, what kind of provider or therapy works best for what kind of patient. So really on the front end, measurement-based care allows us to say, this provider is particularly skilled. If you look at their response trajectory with, say, social phobia or generalized anxiety, they do a great job. So this is the person who can help you the best and the quickest with that, versus some other, who may be more skilled in treating, mood disorders or bipolar illness. So, and again, it's not, the point of doing this routinely is it gives us a large enough data set that it's going to be significant. So I think from a provider point of view, that's helpful. From even a patient point of view, it really helps on the front end with sort of best match. There may be characteristics that we could delineate that we can help connect the right provider with the right patient. So we don't waste time with them, interviewing multiple providers. The other key piece that's very important, Optum and other payers are really looking to sort of change the way we reimburse for care. So rather than getting, this model of sort of encounter-based payments, you see someone, doesn't matter what you do, we pay you, right? Measurement-based care allows us to sort of go more into these value-based arrangements, right? If we know that you treat someone with major depression really well and you can demonstrate that, we could give you sort of a case rate or a bundled payment. We're going to give this patient, they have this severity, which we know, and you're going to get them to this place in roughly this amount of time. So it does away with some of that sort of administrative, friction or burden that I think is really difficult on the system. Providers don't like it, and it's expensive for us as a payer as well, to administer it that way. From a policy, point of view as well, I think it really allows us to sort of understand also what are the needs in a given area or system, right? You can sort of understand, it gives you that sort of population health view, which we don't have right now. We are flying blind, and we collect a lot of data as as a large sort of payer, but I can tell you we have a very incomplete view of whether we're actually able to meet the needs of a population, and ultimately for the companies that support these plans, certainly in the commercial space, what they want to know is what value are they getting for all the money or investment that they're sort of putting in the employees. How do we know that the benefits actually are helping them? And this really allows us to sort of go back and say, yes, this is we're taking care of disease. We can use this to really model and change the network so that it meets the needs of their population.
This is all really game changing. And speaking of which, Dylan, could you weigh in a bit on how digital behavioral health technology could help with this?
You bet. So I mentioned earlier in terms of some of the challenges out there that are real in terms of implementing the systematic collection of patient-reported outcomes. And so while, of course, many electronic medical records and other digital applications have the functionality and the capability to make the collection of this, so think, whether you're interacting with an app or an online portal that is in essence kind of survey-based forms. If you imagine the PHQ-9 and 9-item scale of depression symptoms, that survey-based administration technology can really help with a lot of the administrative burden that surrounds measurement-based care. And so given that, for the demonstrations, measurement-based care demonstrations that Optum is committed to and resourcing, we've partnered with a wonderful technology vendor in Mira, M-I-R-A-H. And Mira, along with other partners that are out there that we're equally working with, Tritium being another, that these types of solutions have identified where those pain points are across each one of the different stakeholders in this space. So from the patient or member or consumer angle, how do we make it easy to collect this? How do we, from the provider level, ensure that we can automate reminders, prompts to make sure that we're collecting this information routinely? How do we balance the experience from the consumer standpoint, where it doesn't feel like it's just yet another notification on your phone, but there's real thoughtful timing and cadence in terms of not just using the same measure every visit, every time, but being thoughtful around meaningfully dispensing that, if you will. So technology helps us in terms of the data collection, but also in terms of taking that disparate data and making it, positioning it in a way that is meaningful information. And I think that this is really important, that is actionable at the time and point of care. Something that's critical to measurement-based care is that this type of information, patient-reported outcomes, that it's available to the provider in session. Because to really embrace this beyond just a data capture exercise and to really embrace the full integrity of the evidence-based practice, there needs to be clinical and contextual meaning made in conjunction, this co-creation of understanding between both the patient as well as the provider. How do I set this number around, say, your PHQ-9 score in the context of what you're struggling with, of what we've been talking about? And so this personalization, a nod to what Dr. Rosenzweig mentioned in terms of personalizing care, this is really important. And so with technology, platforms to make this information viewable, usable, and meaningful in an actionable and timely manner has been really phenomenal. So case in point, to be able to graph and track trends over time, to be able to pair up, say, changes in symptom scores with what's going on in a person's life. Loss of a job, just fell in love, about to go on vacation. And you can start to see, as you begin to put numbers and able to quantify symptom change to the context of somebody's real world their life, all of a sudden you can really kind of see the full value of this coming out. So Mira, for our demonstrations, has been a wonderful partner. I will also just add that it's easy for us to think about this as being a technological solution only. And I know I mentioned this earlier, but I really want to hit this home, that the technological aspect of implementing, say, a new technology versus the adaptive view in terms of how to embrace it and what that behavior change needs to be at each level is something that we've prioritized and that we're really putting front and forefront in terms of how we're thinking about implementation science being applied to these demonstrations.
What a difference that could make. Really interesting to see how you're using technology to implement measurement-based care. Martin, you alluded a bit to it earlier, but can you talk more about how you could imagine a future where measurement-based care is really more broadly used? What's different?
Yeah, sure. So, this is the part that's kind of really exciting because it's really possible. So, one of the things that we experienced over the last year with the pandemic is there was this radical transformation in the delivery of care in the behavioral settings. So I'm going to go back to 2019, maybe 2 or 3% of outpatient visits were done virtually. Currently, it's somewhere between 60 and 70% of all visits are really delivered through some kind of a platform. And, if you think about the pandemic forced that adaptation, right? We struggled for years to really get from 2% up to, 60, 70%. I really see this as an opportunity to leverage that change. Providers have adapted, patients have adapted, but there's a key piece there as well in terms of what that changes. So imagine the experience, and I think Dylan was alluding to this for the patient, what is different. So you're going to, before you even set up your, appointment through a virtual platform, you would get delivered to you a set of questions, which are really tailored around your condition and what we may know about you. So it probably would take less than 5 minutes to complete. Before the therapist even sees you and says, "Hi, how are you?" My favorite question in therapy, because no one knows how to answer that. They would know that you're suicidal, you're more depressed, and you don't really feel like the therapist is helping you, right? You're not really engaged. So think about what that next session is going to be like, how different that is, because the therapist knows right away what it is they need to hone in on, right? And the fact that you're not feeling like it's helpful really opens up a discussion, which I think is foundational to what's different about measurement-based care. The patient becomes a much more active participant in their care because you're looking at these sort of measures together and sort of are able to discuss progress versus just report out on stressors or things that may gone on in the week. Like, let's try and understand why you're still depressed. What's going on. I think there's another piece here as well, looking into the future, which is really around getting better at some technology that could identify this without questionnaires, wearable technology. I was on a call recently with NIH. I mean, there's some things around voice recognition that would be able to track. So it's not, right now we're in the, you need to check a box. But I really see in the future that some of this will really happen in the background. The telehealth platform would be able to, understand intonation of someone's voice or a wearable if they're having. I'm not going to give ideas to any of the companies that create wearables, but I know they measure blood sugar and pulse and all this kind of stuff right now. But there may be in a future where we can measure those things as well. In a way that really makes them actionable. Can you imagine if we figured out a way we could understand out of session that someone was doing worse and was more suicidal? Wouldn't you want to know that versus waiting for a week or two to discuss that with your therapist? So I think, and there actually is some technology out now that sort of looks at, sort of digital phenotyping around how you engage with a smart device that can sort of allude to changes in your emotional well-being. So I really see this as sort of a first step. It's about enabling the technology and then really allowing for sort of some creativity around how we actually get that data.
lots of really exciting things happening with tech. And speaking of tech and related scalability, Dylan, could you talk a little bit about what does it take to scale measurement-based care and challenges that likely come with that?
You bet. So we talked about technology. We've talked about the different platforms that are being used out there. Again, in a network of our size, there are so many different models of what care looks like in different enabling technologies, and further, the types of just highly variable practices that are out there. And so what we're seeking to do is to find some common denominator, both from a practice standpoint in terms of having a shared agreement around measurement, what matters most to measure and how for whom, but also from a data and interoperability standpoint. We need to do a better job in healthcare more broadly to be able to share discrete and important data across disparate systems more effectively. So some of the challenges right now that we're facing as we look to scaling this practice, as well as the data sharing within our network, really comes down to the technology. But also there's the just the change management aspect. I referenced 10% of psychologists, 19% of psychiatrists, and likely much fewer when it comes to master level providers currently doing this practice. So what we're asking is fundamentally a practice shift. So we know that this is coming. Many payers such as ourselves see that this really is on the horizon. It's not an if, but it's a when. And so what we're trying to do right now is to identify those progressive behavioral health organizations that share our value when it comes to the value of clinical measurement, that are interested in using data to drive improvement and improve health outcomes, both behaviorally and otherwise, as well as those that are not scared of doing some learning together. So some of the challenges I called out, of course, technology, the practice pattern changes, but also in terms of there continues to be a healthy degree of cynicism on the provider side around how this information will be used. And so what we've continued to do is to make sure that we are being transparent and very clear around the full value proposition. That sure, we as a payer have a stake in this, but at each level, so much value can come: patient level, provider level, practice level, payer level, policy level, and beyond, when we can commit to embracing measurement-based care in a standardized way.
It's just remarkable to see Optum's leadership taking the charge with measurement-based care. Super inspiring. I really hope that measurement-based care can become the standard throughout. One final question, maybe Martin, I'll point it to you, is if you were given an opportunity to put out a call to action to the behavioral health industry, specifically around measurement-based care, what would that be?
Yeah, it's a great question. So, the simple answer is just do it, right? I think there's a piece, the reason we've sort of stepped up and made this important issue for us is because, honestly, this is the future of behavioral health care. These psychiatric illness or brain disease, we really want to make sure that we're adopting some of the practices with other medical disorders that really make a difference. So, we're not trying to come up with solutions that are unique to, Optum or United. We're looking to sort of help people in terms of how they run their overall practices, knowing full well that they take care of, patients that have other coverage. So my challenge to the industry is really to join in on this, is to sort of understand how transformational this is. At the end of the day, I always go back to this. We're in the business of taking care of people. And I think that's the call to action. We want to be in a position where we're better able to do that. And that's the promise of measurement-based care.
Excellent. This has been super insightful. Thank you, Dr. Ross, Dr. Rosenzweig, for joining me. I'm really excited to learn about all of these incredible initiatives around measurement-based care. Thanks for your time.